Pauline Love. I'm a GP and I'm the end of life clinical lead for the ICB. Uzma, do you want to introduce yourself?
Yes, thank you, Pauline, and good afternoon, everyone. I'm Uzma Rani, and I'm the Palliative and End of Life Care Transformation Lead at the ICB.
So today, what we're going to discuss is what do we mean by dying with dignity? What are the national requirements for end of life care? What about the assisted dying bill? And you probably know more about that bill than I do. What is the Derby and Derbyshire strategy for end of life care? What are the priorities of the Derby and Derbyshire End of Life Care Board? And what are our challenges? And most importantly, we need your voice to be able to shape everything that we do. So, dying with dignity means different things to different people. And before I go to my next slide, a little bit of what I think dying with dignity means. I think dying with dignity at the end of life care involves ensuring a person's death is as comfortable and respectful as possible, considering their wishes and preferences. And this includes respecting advanced care plans, things that they've thought of throughout their lifetime that they want to achieve at the end of life, maintaining privacy and dignity, and ensuring appropriate care in the location of their choice, whether this is at home, a care home, a hospice, a hospital, on a barge, wherever they want to be. And I think it is really important that that dying with dignity, certain aspects are included in that. And I think respecting advanced wishes are really, really important. While we're fit and young, most people know that they want to die in peace or in a certain environment or on a sun lounger in the Maldives. And I think it's respecting their wishes to the best of our ability, providing that comfortable care, making sure symptoms are as well controlled as we can possibly make them. And that's not always easy, but I think it's not giving false promises also. Supporting the loved ones of that person that is dying and maintaining privacy and dignity. So this is artificial intelligence idea of what dying with dignity is. I just thought I'd put this up to see what you thought. That's pretty much the same thing, doesn't it? A few minutes. So I think facing death with courage, grace, and acceptance, while also ensuring that one's wishes and values are respected, is really important. And it means different things to different people in different cultures and different backgrounds. But I think it's good for an artificial intelligence to be able to come up with that. So what I'd like to do is, before we get into the actual nitty-gritty of the presentation, is for us to do a bit of a Slido. So I'd like your opinion, and this is for you, your loved ones. With dying with dignity in mind, what matters to you and your loved ones? It's really important that we get your voice. If you'd like to start filling in your Slido or put something in the chat, that would be fantastic. Finding your place of choice, I think that's really, really important. Being free from pain and comfortable. Calm and happy place. Good generalist and specialist care, really, really important. We'll touch on that a little bit later. Support for family and friends. Bereavement care is really important when someone's coming towards the end of life. They want to safeguard their loved ones. Love and compassion. Absolutely. How do you measure acceptance? That's a really, really good question. Very, very difficult. And it is person specific, isn't it? Coordinated, joined up care. Listening to what someone needs and wants. Perfect. That's a good theme, coordinated care, isn't it? Joining things up, treating the person as an individual. Care planning is so important, but it's important to care plan prior to your last weeks of life. Get things down, make people realise what you want. Family and friends, really important. Or someone that you like, your neighbour, if you've not got family and friends. Perfect. So people are still typing, so I'm going to give you a few more minutes. If there's a few more things you want to say on that one, you can still put things in the chat. There's no external distractions. Being myself until the end. And if that's someone that likes to wear a shirt and tie, like my husband's grandfather to the end of his life, and I think, why not? That's exactly what he was like every day of his life. I'd like my cats around when I come to the end of my life. Other people might think that's not very good, but that's the way I want it, having spiritual and emotional support. And that means different things to different people also, spiritual support, emotional support. And these are all really things and things that our hospice colleagues do particularly well. I want to move on to the next question. Thank you for that. What experience of end-of-life care have you had for maybe it's your loved ones, a friend's friend, a friend's loved one? And was it a positive experience or could things have been better, do you think? These might be a bit more difficult for people to answer. It brings back some feelings and some thoughts that some people might not want to remember. I think a friend going to Switzerland for assisted dying is interesting, isn't it? We're going to touch on the assisted dying bill. I think that's important as well. Relatives having different experiences, different understandings of the process. Some people might be in the healthcare profession, they know a little bit more about what's happening, and others may not. And that is really hard when you're trying to coordinate care as a relative. I think that must be difficult, that last one, lack of honesty from medical staff about how ill the individual was. And we do see that from time to time. In general practice, we used to see people having chemotherapy right to the very end. I remember seeing a very lovely gentleman who had private chemotherapy for his lung cancer. He actually died in the private hospital with his drip still going through with his chemotherapy. So it is difficult. And our aim in Derbyshire is to make things better, but we need to listen to our general population as to what we need to do. And lots of people think, why do people die in hospital? But some people do die in hospital, and some people want to die in hospital. And majority of the time, the hospital are really respectful and the death is a good death. It's when people are ill prepared, it can be a bit more difficult. But our hospital staff do a fantastic job. We've got some great palliative care teams out there in the hospices, in community, in the hospitals. I think, hands up to them, they do a hard job. A couple more people still typing. Thank you for that. It's difficult to think about someone dying, and especially when it brings back some memories that might be difficult experiences. So thank you for that. So we touched on the Swiss model. And what about the assisted dying bill? You probably know more about this than I do, but as you're aware, in November 2024, the House of Commons voted in favour of the terminally ill adults end of life bill by 330 to 275. The form of the bill that they voted on sought to legalise assisted suicide for terminally ill adults in England and Wales with a life expectancy of 6 months or less, with the approval of 2 doctors and a High Court judge. That was when it was first discussed. Since then, there's been lots of discussion, lots of media coverage around what's happening with the bill. The High Court judges raised concerns regarding having to review every single case. So their role in the assisted dying bill was removed from the bill. Currently, the legislation proposes a voluntary assisted dying commission with expert panels to assess applications instead of using a High Court judge. Interestingly, from a health point of view, the Royal College of Psychiatrists that were also named in that bill to give some support felt that they can no longer support the bill from May this year. They felt there was a high risk for suicide in people that were terminally ill. They felt they needed a holistic assessment of unmet needs for those dying people. And they felt that assisted dying was not a treatment option, that the mental capacity assessment, there's no framework for assessing decisions about ending one's life, and felt how unclear it was of the psychiatrist's role in this. They also urged there was not enough psychiatrists to help with the assisted dying bill, and that professionals must be able to object to any involvement within the bill that meant that they would be approving or disapproving if someone wanted to have assisted suicide. And they felt there needs to be a robust professional standards and oversight committee that went alongside, and felt that the physical effects of a mental disorder should not make a person eligible for assisted dying. And in response to that, also, the Royal College of Physicians, also in May 2025, said they felt there were deficiencies in protecting patients and professionals, so they've also cannot support the bill. They felt that patients must be able to have an equitable choice of services as they approach the end of their life. They felt that doctors must have an option to absent themselves from any decisions. Decisions around prognosis must be by expert clinical professionals and those who know the patient the best. They felt that prognostic uncertainty must be understood and accepted by the patient, because we do hear stories that, for instance, someone that might have pancreatic cancer may be given 3 to 6 months to live, because looking at research, that's how long people can tend to live, but some people might live for 2 years. So it's that uncertainty against prognostication. And decisions on capacity and safeguarding around coercion are also on the minds of the Royal College of Physicians. They felt that there must be informed by face-to-face assessments of skilled professionals and those trained in the Mental Health Act to assess a patient for remedial suicide risk factors, and it's really important that where do we draw that line? They want close regulations and monitoring of those services that may deliver assisted dying, such as your Dignitas. They felt that medicines must be regulated for safety and efficacy. So how good are those medicines? Are they going to cause issues if that person doesn't die when they've had the medications? They also felt that assisted dying services must not divert resources from the end-of-life care. So end-of-life care in the community, in our hospices, in our hospitals, should not be diverted for this other treatment option. And interestingly, the Royal College of General Practitioners, of which I'm one, neither support nor oppose the assisted dying bill. So they've got a very neutral stance, but they want robust regulation and safeguarding. Any assisted dying service should be distinct from core general practice and palliative care. They have a right to refuse, and that I think to stress the importance of strengthening the palliative care services that we've got within community and hospitals to ensure patients have the best possible support at the end of life. So potentially reducing the reliance on assisted dying. So currently the MPs ran out of time at the last discussion, so there's further debate is going to be on the 13th of June. Which in itself shows how complex this assisted dying bill is once you get into the kind of the discussion and the nitty-gritty of it. So what are the national requirements for palliative and end-of-life care? And these come from NHS England. So we've got the assisted dying bill, which we know is from the MP Ledbetter, but we have got national requirements for palliative and end-of-life care services. So all integrated care boards have a legal responsibility to commission palliative and end-of-life services that meets the needs of their population. So it's great having you on board here to tell us what you need and what you want, and we need to listen to your voices. And we're collecting data currently to see why people use certain services or don't use certain services. But the Health and Care Act also mandate the ICBs to commission specific services. NHS England Palliative and End-of-Life Care National Delivery Plan 22 to 25 emphasises key areas for improvement, including access to the care that people want and need, quality of that care. So for me, you don't just put carers in and don't worry about the quality. We need to look at the quality. We need to be assessing quality of care. And how we make our services sustainable. So we know that hospices struggle for funding. We know every year they have to look at their contracts, and obviously we need a longer term plan for hospices to maintain sustainability. NHS long-term plan of 2019 shows that end-of-life care is a key component and outlines the commitments of palliative end-of-life care, including increasing identification of people likely to be in the last 12 months of life and those people being offered personalised care support and planning. So we know that we can recognise some people that might only live for the next 12 months, a little bit longer, a little bit less in some instances. And I'll go through a little bit later how we plan to look at that in a bit more detail within Derby and Derbyshire. Then, of course, we've got the NICE quality standards. That's the National Institute for Health and Care Excellence for adult and children's end-of-life care. And I've underlined and put in bold and children's. We don't get many children dying in Derbyshire, but the ones that do come towards the end of life, the majority of them want to die at home, but currently we don't have the supportive services in the out of hours period to be able to support those children to die in the place that they want to be. So the other choices are hospice in Loughborough, which is a fantastic hospice, don't get me wrong, it's really lovely and great grounds, or hospital. And they get equally good care in hospital. But lots of children want to be at home with their family and their friends and their animals around them. So what's our local strategy? Our local strategy is obviously unique to Derby and Derbyshire, but we do work with other ICBs. I'm part of a network in the whole of the Midlands, and I used to work for NHS England in the East Midlands around end of life. So I talk to other clinical leads that do similar jobs to me, and we have regular meetings to see who's doing what and how can we learn from best practice. So our local population statistics, we know that 1% of that population in the UK are going to die, and I am sorry that I've made a spelling error, die of an expected death each year. And we have something called the Gold Standards Framework, which shows us a proactive identification guidance. So we can look at our registers as GPs, we can look at people's diagnoses, we can look at their prognosis, we can look at their comorbidities. So have they got heart problems? Have they got lung problems? Have they got kidney problems? And we can say that that person may only live for the next 12 months. And that gives us a really good indicator. So it could be someone with heart failure, somebody with chronic obstructive pulmonary disease, somebody who's got cancer, who's going through palliative treatment, although treatments are getting a lot better, somebody with neurological complaints such as end-stage Parkinson's disease or motor neurone disease, people with dementia. So we do know that life expectancy is reduced with people with dementia. And those with frailty and older age people. We have got some people in South Derbyshire that are living to be 101, 102, but we can expect them to die at any time purely because if they're 102, the heart's 102, the lungs are 102, the kidneys are 102, and people can't sustain that amount of work. Their organs can't sustain that amount of work. So we can say pretty much for sure that around about 1% are going to die, and we can name those people really. So we know we've got 1.2 million people registered with a GP in Derby and Derbyshire. So 1%, 12,000 are estimated to be in their last 12 months of life. So we know that, and we should be preparing those people, and we should be preparing services to be able to utilise that amount of deaths, if you like. So the Joined Up Care Derbyshire End of Life Strategy, which was last revised in 2023, shows us that we need effective neighbourhood-based planning. So for those that have been on Place Alliance meetings or are closely connected to the ICB, you know we've got Place Alliances, we know we've got neighbourhood working. And this is where groups of providers, public health, councils, voluntary services, anybody and everybody within Derbyshire come together and look at better planning for care and services within the neighbourhood. We need to enable local, compassionate, accessible, personalised and coordinated end-of-life care plan. That's what we want to do. That's what we aim to do. That is my overall goal before I retire completely from end-of-life care, that we maintain that compassion, but we maintain accessibility, and personalised care planning is so, so important when someone comes towards the end of their life. But also coordinated care is, because services are very different out there, and we'll touch on that a little bit later, but coordination is key. Coordination, communication. We want to support collaborative action by system partners, as we've said, those neighbourhood-based partners, to make those improvements that we need for our citizens, for the benefits of our citizens, whilst maximising the most efficient use of resources. We've not got a never-ending pot of money, but we need to use that money wisely. And currently, Uzma and myself and the other end-of-life people on the board, we're looking at how we can best utilise services and how we can tweak services to make them more responsive. So we've got an end-of-life board that consists of someone from each provider of end-of-life care, as well as Health Watch, as well as our voluntary sector. We have ambulance service on there, we have chief execs of hospices, we've got an array of people on there, and we have aspirations. We've got a vision for the future. So we need to reduce that number of inappropriate admissions in the last 90 days of life. And if I tell you, in 2024 to 2025, we had a proportion of people over the age of 75 in and out of hospital more than 3 times in their last 90 days of life, and that equated to 80,000 bed days. It wasn't a lot of people, but because they were going in and out of hospital, it equated to 80,000 bed days. And I don't look at things in terms of finance, but if you look at the finance surrounding that, and you've got to look at the cost of bed days, that would have been a cost to the system of £27 million. Imagine the services that we can get for £27 million if we could reduce the amount of inappropriate admissions. And inappropriate means that people that are going into hospital that don't actually need anything when they get there, but they get stuck in a bed because there's no services out in community to support them. We need, again, to increase that number of people on the palliative end of life care registers to meet the national target of 1%. And it's not because we want to hit a target, we want to give the best care for our patients that we can. We need to increase the number of our patients with a respect plan, and that's a treatment escalation plan. That's it's not as an advanced care plan would generally be within end-of-life care, but it is a plan that tells everybody what you want, where you want to die, what you don't want to happen at the end of your life. And we've got a big push in Derbyshire to get this truly digital, which means that we fill out the respect plan once, it gets put on the Derbyshire shared care record, and everyone can see that is going to be dealing with your care. And we need to increase that number of patients that are dying in their preferred place of death. So we can do audits around that to see if we're hitting our targets and actually doing what population wants us to do. So looking at the preferred place of care, we know that majority of people want to die at home. Round about 50 odd percent, 60 odd percent, 80 odd percent, depending where you are in your life, who you've got at home, want to die at home. We know that a majority of older people, and we've got around about 20% dying in care homes at the moment. We know we've got about 4.5% of people dying in hospices. But we've got a large number of people dying in hospitals, but they don't necessarily want to die in hospitals. So what services have we got to try and prevent people going into hospital for unnecessary admissions? We've got Team Up service. This is part of your neighbourhood team. It's a home visiting service that visit people over the age of 65 that are housebound. We've got GPs. Our GPs are working very, very differently currently, and Team Up do a lot of the home visiting service with GPs doing other visits. As you're aware, the GP contracts are up in turmoil at the moment, and some GPs are struggling with workforce and the amount of workload that they have. We've got our rapid response nurses in community by DCHS, and again, their workload is escalating as our population are getting older and people have got more needs. We have our specialist palliative care services, which is our hospices. We've got a hospice in hospital, which is at UHDB, with our specialist palliative care at Chesterfield as well. The hospice roaming service, we've got 2 hospices delivering our roaming service, which we'll touch on. We've got a Marie Curie service in the south of the county. We've got our end-of-life virtual ward in the north of the county run by Ashgate Hospice. We've got a dementia palliative care service that is aimed to get people with dementia that might go into hospital for things like a chest infection, a urine infection, but then get stuck in hospital because it's hard to get them out with dementia. So we've got our dementia palliative care service. And we've got a palliative care urgent response service that works at the weekends to support people. So you can see we've got a lot of care in community, but it's not joined up. It's not all coordinated, and it's not delivering what we want it to deliver. So a bit of a visual, thanks Uzma, these are great slides. So we're looking at our current bedded provision. So we've got specialist inpatient beds, Ashgate Hospice, that covers the whole of the north. We've got the Nightingale Macmillan unit that covers UHDB, which is in Derby. We've got specialist hospital palliative care services at Derby and at Chesterfield, and we've got some fantastic consultants. They are very overworked at the moment, as you can imagine, because of the sheer amount of people going into hospital towards the end of their life. We have got our community hospitals with specific end-of-life provision. So they might be at the Whitworth Hospital in Darlydale, St Oswald's in Ashbourne. We've got Ward 2 on London Road, which is in South Derbyshire. And we have our generalist acute beds. But you can imagine those generalist acute beds we should not be filling with our dying population who might want to die at home. And we've got out of area specialist inpatient beds as well. Our current out of hospital provision is varied and wide. So we have our daycare and wellbeing services. That's all the hospices in the north and south. So we've got Treetops Hospice, which is south. So we've got Nightingale Macmillan unit, which is South Derbyshire. We've got Blythe House, which is High Peak, and we've got Ashgate. Fantastic hospices, do a great job, and look at resources. We need to be thinking about how we can sustain that care. We've got fantastic end-of-life facilitators who are brilliant educationalists, and they're based at Ashgate Hospice and UHDB and Treetops. And together we are looking at how we put in better education for all generalists and specialists alike, and, you know, doing things for the general population. We have adult and children's bereavement services that's run through our hospices. We've got OTs and physios that are specific to end-of-life patients. That's Ashgate and in both acute trusts and with our community services. We've got our palliative care urgent response service run by our out-of-hours service and the roaming services at Treetops and Blythe that actually do what they say on the tin. The palliative care urgent response services goes out and see people in crisis. They then hand care back to the community nurses, but also those patients can use the roaming services. So anyone can ring the roaming service at any time at night time and they will go out and they can do cares for patients. So we've already said our hospice coverage. So we've got a large amount of specialist care out there and a little bit of generalist care. We've got our hospice at home service as well, but we need these provisions to be expanded. So a little bit more work from you. What would you like from your end of life services? If you could choose something, platinum standard, what would you want from your end of life services? What can we help with? Good answers. Adequate resource for the 24/7 coordinated joined up care. I like it. Suitably trained staff to support. Absolutely. Adequate care packages. Yes. Someone to contact when a crisis happens. A named person to contact for help. A point of contact. More end-of-life specialist support for people dying in care homes. Yeah. Identifying earlier those who may need end-of-life care planning. Absolutely, planning is key. Especially with the dementia diagnosis, it's really difficult. It's really difficult for relatives and loved ones when someone's got dementia. How long will it take someone with dementia to die? Very, very difficult question. And sometimes it can be predictable depending what kind of dementia someone's got, but other times it can be very, very unpredictable. Adequate social support to allow people to stay at home and get home from hospital. Yes. More responsive care packages. Recognition of people who are unpaid carers. Absolutely, we need lots of support for unpaid carers. It is a very difficult time. Thank you for that. That's really, really interesting. And I think the themes are pretty much what I would have expected. So you can continue to write in the chat. I can see some people are still participating. I'm not going to rush. More education for the public to support caring for family members. Yeah. Improve use of communication systems. Absolutely. And that's what some of our virtual wards are doing, looking at communication systems, more responsive packages. You can still put some things in the chat if you think of something later. These will all be anonymised. So what are our challenges? As you've said, interesting, lack of coordination of end-of-life services. We are looking at different models of care to join up all providers of end-of-life care. To be honest, our end-of-life providers are absolutely fantastic. They are also aware that we are not particularly joined up. There's lots of working in silos, but lots of work that needs to be done to join that up, and it's how we do that. And some of the consultants, specialist palliative care consultants, myself and other service providers that are clinicians are looking at how better we can do that care. Reduction in workforce for packages of care in community for end-of-life patients. Definitely, there's definitely a lack of workforce there. We are looking at the fast track solutions. So fast track is the way we can get someone better care at a quicker time, so we can recognise someone's dying, and we're looking at how we bring that in-house, and we can do assessments, get a bespoke package of care. And what we'd like to do is those people providing that care to have specific education around end of life and be supported, because looking after someone who's dying is very, very difficult, as you will all be aware of. And if you're someone in an agency who might be 19, 20-year-old, who've never seen anyone die before, and all of a sudden you're looking after someone who's dying, it is very, very hard. It's hard to watch. It's hard to know how to support them, and it can damage your own mental health. We do have difficulty estimating demand and capacity for non-specialist end-of-life care, but we know the numbers are growing. We know from the people going in hospital in the last 90 days of life that we need some non-specialist end-of-life care out in community and a more responsive service. Commissioning and contracting in the current climate, as you're aware, is very, very tricky. I don't get involved in the commissioning or the contracting. I look at the quality of care that we're providing for patients. But in this current climate, with NHS England changes and Integrated Care Board changes, things are becoming more tricky for the contracting team and the commissioners. And financial planning is going to be difficult moving forward. So what we're doing to meet your needs, what we're trying to do to meet your needs, we're trying to improve the coordination of care by revisiting the 24/7 palliative and end-of-life care advice and support line. So we're looking at something called Doing Hubs Once. So we've currently got a central navigation hub, which is a telephone line. What my ideal is that we use that central navigation line to actually coordinate care where it's needed, but in a timely fashion. And if someone phones a one telephone line and gets that care that they need, then things will feel and be a lot better. We need to increase the number of people with a respect plan. That means we recognise when people might die in the next 12 months. We have those conversations with that person and the ones that they want us to have those conversations with around them. And we can use that Derbyshire Shared Care Record platform to provide training and education to all providers and to get the right record at the right time, at the right place, so everyone can see it. So if a paramedic gets called out to someone who might be short of breath, for instance, if they've got a lung cancer, the paramedic can look on that Derbyshire Shared Care Record, see there's a respect plan, see what that plan says, and they can support that person. We've done lots of education with our ambulance service, and our ambulance service now have got a standard operating protocol and procedure that they can give anticipatory medications to people that are dying at home. They can give subcutaneous injections, whereas before they would have to give intravenous or intramuscular and convey the patient to hospital. So we're doing lots of work, but it needs to be honed in and spread out, if you like. We're promoting the existing end-of-life online toolkit as a support resource where all palliative end-of-life education will be hosted. So anyone can go onto the Derbyshire Alliance for End-of-Life toolkit. You can look at that anytime you like. We're open and honest and very transparent. And the more people that look at that website, the better. We are going to have a better, bigger platform for the general population. We're developing the general list to our urgent response for all age end of life, and we're working with the children's services as well. So we are looking at how we improve that, working with advanced paramedics, particularly over the weekend, working with the palliative care urgent response service so they can directly dial into that service. Looking for ways of expanding services to be over 7 days a week, because the palliative care urgent response service do exactly what they say on the tin. They will go out and they'll do that urgent care and they'll refer back to the community nurses when that care has been done. So they can carry all medications, they can carry opiate medications, Once they're called into a patient in crisis, they can prescribe medications, leave medications, administer medications, whether it's a syringe driver or not, can catheterize people, wash people, organise equipment. So it's a really good service for us to try and expand. We want to expand that with a view to the home visiting service. That's our team up to include the generalist and end-of-life care. We already work very closely with our specialists at the weekend from Ashgate and UHDB. And we need to ensure that coordinated care for dying people of all ages. We want all providers working together. That's the ultimate aim, which we try and do, but services can't always be as responsive when they're working kind of in silos. We want to improve the efficiency of the specialist palliative care provision. We know our hospice consultant, we know that our hospital specialist palliative care consultants and nurses are inundated. We don't have enough specialist palliative care provision to be able to give good end-of-life care to 12,000 people in Derbyshire. So we've got to have a different model. We've got to work differently. We've got the hospice at home models, which we're hoping to increase that hospice at home model with the fast track continuing healthcare changes. That's about a year, 18 months away, but we are making moves. We want to maintain awareness of the hospice model is for planned care, not urgent care, but they are so good at the planned care for people. We don't want to dilute that. And currently it's adult only, although some of our specialists do support children at the end of life. We need to transform the existing end-of-life virtual ward service into a more responsive, coordinated service for end-of-life patients of all ages. I know that's been looked at by NHS England, all the virtual ward models are, but it's how we best utilise these things. So I mentioned the continuing healthcare fast track provision. We're looking to develop and transform that into a more responsive and flexible service, working with our ICB quality team. That will be getting bespoke care. So if someone needs one call a day for 2 hours, why not? If someone needs 2 calls a day for 10 minutes, why not? If someone just needs a night sit, why not? We should be responsive and we should be a bit more personalised. We're currently working with Marie Curie on a specific quality improvement project at Chesterfield Royal Hospital in the emergency department to gather some qualitative insights into why people are admitted to hospital. As I said earlier, 80,000 bed days in a year. Why have they gone into hospital? Is it because we've not got the right supporting community? Is it because the relatives panicked? Is it because we've got inexperienced paramedic staff? We're not sure yet. So we're going to do some work with CRH and help our specialist palliative care team there, who are also meeting and going to support us with that. And that's using an innovation fund, which is really good for Marie Curie. So they're also going to work with 3 North Derbyshire primary care networks. That's the clusters of GPs to support some of their generalist practitioners that might be struggling a little, that might need a little bit extra support. So we're doing all this because you matter, because you are you. You matter to the last moment of your life, and we will do all we can, not only to let you die peacefully, but to help you live until you die. That's Dame Cicely Saunders. What a lady she was. And that is what we want from our end-of-life provision in Derby and Derbyshire. So everyone dies in the place that they want to be and they're happy. Thank you. Any questions? I'm now going to stop sharing my screen.
Pauline, that was amazing. Thank you very much for that. I really loved it. And I was really pleased to see all the responses to Slido as well, people getting engaged. And it was interesting to see that there were themes in there. So in general, although there were some other things, people generally have the sort of same hopes and fears on the subject as well. So in terms of questions, so please anybody put stuff into the chat or raise your hand and we'll come to you. We do have one in the chat to start us off, and it's from Jamie. So Jamie has asked, what are your thoughts on the ethics of using PPOD, which is preferred place of death, as a reliable measure if we know we are often unable to meet this due to limited resources? For example, hospice beds becoming increasingly limited, community resources stretched, and so on.
Uzma, you must have your thoughts on this, as I've got my thoughts on this. It's a difficult one because from an NHS England point of view, we have to collect specific measures for NHS England. Preferred place of death is an interesting one, and I think because we haven't got the things in place in community as we would like them, I think it's going to be a difficult measure, and it's not being collected currently, to be fair. And one of our reasons for asking for this is it gets a conversation going. We need to identify those people that are coming towards the end of life. We need a conversation, and if we don't know where the preferred place of death is going to be, it's more difficult to inform services as to what we should be doing. It's not reliable, Jamie. I fully understand, but we have to start somewhere. That's my personal view.
I agree. Yeah, I agree with Pauline. It is one of those national indicators that is exactly like Pauline said, is just to get us thinking about it and reviewing what access looks like across the different services. Because we also know from national data and from local data that when you do ask people where they would prefer to die, the vast majority of them say they would want to die at home. So it's what can we do to try and support that, and where people don't want to die in a hospital bed, for example, what do we need in the community to be able to support those patients and their families to be able to die at home? So that might be additional support to your more generalist providers of end-of-life care. So that could be your GP practices, community matrons, district nurses, those people that would have regular contact with patients and their families throughout their journey, and not just in the last days of life, so that everybody across the system is upskilled in recognising dying and supporting patients to die with dignity, so that is not just left to the specialist services, so that we utilise specialist services for our most complex patients, actually, because what we found from the data was that something like 75 to 80% of patients who die don't have a complicated death, or not that they don't have a complicated death, but don't require specialist services intervention, and could be managed in the community with the right support.
And we need those specialists for those people that generalists can't deal with and can't cope with. And I've had a patient in her 30s who I couldn't manage her symptoms in community as a GP, and that I'm quite a proactive GP going in on a daily basis or twice daily, but I needed our specialist to help me out with that care, and they did a fantastic job.
Okay, next one now. Leslie has a hand up. Leslie, do you want to unmute yourself?
Thank you. I just wanted to pick up on something about the patient's preferred place of death. Having worked particularly with the elderly and with people at the end of life for many years, they don't always know where they want. I mean, when you're okay, you know where you want to die, but when the time comes, it needn't necessarily be the same. And I think there's a difficulty there about the reliance that we have on the stated preferred place of where they want to die and the reality when the moment comes. And how do we balance that actually we can change the prescription, so to speak?
And that's a difficult one. And for me, it's communication. If someone's communicating with that person and their relatives, it doesn't matter where the first preferred place of death is. It's their ongoing, and then we should be having those conversations. Do things still stand as they are? Is your respect plan still relevant? Do you still feel comfortable dying at home? And if they say, no, I want to die in a hospice, that's fine, but then we've got to look at the finite amount of resource we've got in those hospice beds. We've not got a massive amount of hospice beds within Derby and Derbyshire. But it's how we support the people to be able to change their minds and make different decisions. It is a difficult one, though, Leslie, to be honest, but I think it's communicated on a regular basis.
Yeah, I'm just trying to think from a public perspective and trying to get them to understand in the everyday world how it might work for them, could enable people to feel that they can manage better than they could. Do you know what I mean? So it's about getting the education out there. You're on mute, Pauline.
Better. I think it's getting the education out there. but it's also getting that infrastructure out there in community. So if we've got a responsive care element towards someone's end of life, then they will feel more supported.
Yeah.
I used to give my dying patients my home telephone number, and I think in 18 years of being a GP, I got called 5 times, but because they had my telephone number, they didn't ring it because they didn't need it, because they knew they could.
Yeah.
It's when people don't know who to ring, that's when the crisis happens. They don't know what to do.
Absolutely.
So if we can get a responsive, coordinated service with a single number, so that is responsive, I think people would be much more relaxed about things like that.
Absolutely. Thank you.
Okay, are there any other questions from anybody? Anything in the chat? Hands up. Otherwise, it looks, Pauline, like we might get 3 minutes of our day back.
Thank you, everybody. It's been really, really good meeting you. And please, by all means, email me. I'm pauline.love@nhs.net if you've got any questions, or if you want to be involved in anything end of life. We always like people to be involved in things that we're doing.
Just give it a few seconds. There might be. Oh no! I thought it was just some thanks in the chat there. So what I will do is I'll bring this to an end. So a couple of people have put thank you in the chat. So I'd like to thank both the presenters, Pauline Love and Uzma Rani. This was a really, really excellent subject, and certainly in terms of current affairs, was great timing as well. So thank you very much for that. But mostly I'd like to thank our audience. We couldn't do it without you. We do it for you. And if there's ever anything that you want us to cover in the future, please email me, give me some ideas, and we'll see what we can make happen for you. So in terms of looking forward, please look forward to the next edition of Derbyshire Dialogue on the 25th of June. It's another subject that's in the news a lot. It's to do with our dental recovery plans. So at some point today, I'll upload this video to YouTube, and everybody who's on the call today, I'll email details to sign up for our next session, and also the link for today's recording as well. So please do share it and get more people involved. And thank you very much for everybody who came today. Bye bye, everybody.